Dr. Fyezah Jehan is an associate professor and chairperson, Department of Pediatrics and Child Health at the Aga Khan University, Karachi. She is a trained pediatrician and an infectious disease specialist in Pakistan with formal research training in epidemiology and biostatics. And she will talk about prevention and treatment of fungal infection in NICU. So may I request Dr. Fyezah Jehan for the first presentation.
Assalamu alaikum. Thank you very much for the kind introduction. I would, before I start, like to thank a few people who sent out this very generous invitation to me. Dr. Sorry about that. Dr. Irfan Waheed, who is chair of the organizing committee, Dr. Sikandar Hayat, who is head of the organizing committee, Professor Sajid Maqbool, who sent out this special invitation, Major General Salman Ali, chairperson, and the other co-chairs of this scientific session, Professor Akmal, Dr. Khalil Ahmed, Professor Najat Masood, and Dr. Bashir Ahmed Abro. It is indeed a privilege for me to be among this galaxy of stars and share with you my thoughts and experiences about managing infections in the neonatal ICU. So this is a brief overview of my talk. I'm going to talk about basically the basic pathogenesis and burden of fungal infections in the NICU, an outline of management and treatment and prevention strategies, future diagnostics, and future research directions. So, as you know, that up to 64%, almost I would say every 6 out of 10 babies who are admitted in the neonatal ICU are colonized with this common fungus known as Candida by the age of 1 month. This colonization can begin at the time of birth, especially with vaginal birth, where there is vertical transmission, or there can be horizontal transmission through healthcare workers and as a result of the different therapies that we give to our neonates in the intensive care. Inadvertently, a large number of this colonization actually does result in invasive infection. And invasive fungal infections in the newborns are, as a result, they result in high morbidity and mortality. Currently, prior to previous thoughts that this is mostly a late onset disease like we see in the West, invasive fungal infections are actually an important cause of even early onset sepsis. And Candida and the Candida albicans and the Candida species are the ones that predominate. This is data from the US, a little old, but generally Candida infections are the third most common cause of late onset neonatal sepsis, accounting for about 12% of cases. Its incidence in the US data among neonates shows incidence of 150 per 100,000 admissions. The NNIS of the CDC does the nosocomial surveillance of US hospitals, and this is old data up to 2006, which shows that in 128 NICUs, there have been 1,997 cases of Candidemia with a median rate of 7.5%. Very little work has been done around fungal infections in Pakistan. I have tried to highlight a few salient articles, and my apologies to the specialists here who have published in this area previously, but I'm not showing it here. In Pakistan, the incidence of candidemia has been very variable. It has been reported to be as low as 0.9% in infants, up to 12% in very low birth weight infants. And previously, in the early 2000s, Candida albicans used to be the predominant species. But now, as time is passing, we are seeing more and more null albicans, especially Candida parapsilosis, that is the predominant strain in many reported studies. This is a time series showing the neonatal incidence of candidemia over time, again in the USA from 2009 to 2015. In the developed world, there has been a sharp decline in the incidence of candidal infections from 2009 to 2011, obviously as a result of their intense infection control practices and efforts. But following that, the rates have generally been stable. When we look at this by birth weight and the incidence of candidemia by the birth weight, we do see a sharp increase in risk and a sharp increase in the occurrence of neonatal candidemia when the birth weight decreases from 1 kg from the 1,000 grams. So a sharp increase from less than 2% to 4% and up to 12% among the very low birth weight babies. Neonatal candidemia obviously results in difficulty in managing care within the NICU, but it is also an important cause of mortality and specifically morbidity, which is related to poor neurodevelopment. So this is modeling that has been done to show the impact of giving antifungal prophylaxis in the NICU to newborns and its impact on prevention of mortality as well as neurodevelopmental impairment. So for example, if you look at the top row, if in an NICU the rate of candidemia is 10%, and one would estimate that the number of infections are 3,000, we can prevent with fungal prophylaxis, antifungal prophylaxis, we can prevent up to 360 candida-related deaths. Similarly, we can prevent neurodevelopmental impairment in a large number of, in an even larger number of babies. This is a cost savings for the US, and these cost savings are actually equivalent, or these cost savings are much more than the cost of giving antifungal prophylaxis. So clearly, neonatal candidemia has long-lasting deleterious impacts on the newborn mortality and the later newborn health and neurodevelopment. This is showing you the impact of different infections on poor neurodevelopment. And as you can see, compared to no infection or compared to other infections such as the commonly seen coagulase negative Staphylococcus aureus and the other gram positives and gram negatives, Candida mostly results in up to 60% can result in neurodevelopmental delays and neurodevelopmental disorders. When we think about the risk factors, it's common to divide the risk factors among modifiable and non-modifiable risk factors. The most important non-modifiable risk factors that are most extensively studied and described in literature are extreme prematurity, specifically having a gestational age of less than 28 weeks and a birth weight of less than 1,000 grams. This can increase the risk of having an invasive fungal infection between 4 to 8 times compared to a normal term baby or a normal birth weight baby. Other non-modifiable risk factors, so if there has been low APGARs, and resuscitation at birth. Vaginal delivery, babies born through vaginal delivery get colonized early and are at increased risk of invasive candidiasis, invasive fungal infections. Presence of sepsis or shock, which results in giving antibiotics. Hospitalization for more than 7 days. Having DIC with thrombocytopenia, and having abdominal pathology, particularly necrotizing enterocolitis, or having abdominal surgery, significantly increase the risk of invasive fungal infections. Other potentially modifiable risk factors are central venous line placement, an inadvertent requirement and need when managing these small and sick babies, giving broad spectrum antibiotics, invasive mechanical ventilation, giving antacids, particularly H2 blockers, use of systemic steroids, evidence of candidal colonization in the urine, and giving parenteral nutrition, specifically intravenous lipid emulsion, so and femoral line catheters. These are all important risk factors. And I see a lot of neonatologists there. I'm sure they are aware of all of these risks. In the developing countries, we have other challenges, and these challenges, unfortunately, in our low middle income country setup, have been studied very, very poorly. Important things to think about are the infrastructure of the neonatal ICU, the healthcare and infection control practices, the presence and fitness of the stewardship program, overuse of antibiotics and misuse of antibiotics and steroids, general lack of awareness about fungal infections and their importance. Specifically, and this is a very big problem, is non-availability of advanced diagnostic tests and antifungal drugs. And then all of this resulting in poor compliance to antifungal therapy. So these are special risk factors that I think are clearly understudied in our setting, and this is really food for thought and work for everybody here who leads a neonatal unit. So we can generate an immense amount of locally relevant, meaningful, impactful research to solve the problems of our units. This is a slide from Up to Date, and which is explaining the pathogenesis of invasive fungal infections. Colonization is the necessary precursor for any fungal infection, and particularly when we talk about the candidal infections. So surface glycoproteins, which are present on the cell wall of Candida, results in adherence to the different skin, respiratory tract, the urinary tract, the genitourinary tract, the GI tract, any plastic or central venous line. And this colonization then, with the virulence and adherence factors of the fungus, results in the fungus replicating and growing in that area, leading to infectious load. And the load and the risk of infection increases more if more than one site is colonized. Of course, there are very important patient factors. Excuse me. So the neonates have an immature immune defense system. Their skin is thin and moist. There is mucosal skin breakdown. They are at risk of necrotizing enterocolitis, and also infection-related hyperglycemia, presence of plastic and plastic tubes and CVCs. All are patient factors which increase the chance of going from colonization to infection. Then it is so important to stress on the role of medications that we give as treatment for sepsis to our babies. Particularly to mention here are the third generation cephalosporins. Now, I would just take this opportunity to talk about how we have now resorted to giving third generation cephalosporins as the first line antibiotic for treatment of presumed sepsis. This is really in contrast to the WHO recommendation for giving ampicillin and gentamicin as a first line therapy for, for naive babies who come with sepsis. So this is another area where neonatal ICUs can study the long-term deleterious impact and the effectiveness of giving these third-generation cephalosporins, because giving third-generation cephalosporins can increase the risk of invasive candidiasis by up to 8-folds. Other antibiotics like broad-spectrum antibiotics like carbapenems, giving more than a single antibiotic, H2 blockers, steroids, and I've mentioned these before, that these are the ones that increase the risk. Infection can happen in any site, literally. It manifests mostly in the blood and urine and CSF. And if there is a history of abdominal pathology, then also the peritoneum. And this adherence property and virulence then results in dissemination from the primary site of infection to the end organs and can result in a myriad of manifestations in, the heart as endocarditis, in the bladder as a fungal ball in the urinary bladder, as meningitis, encephalitis, brain abscess, endophthalmitis, so fungal infection of the eye, abscesses in the liver, splenic abscesses, cutaneous candidiasis, bone infections, septic arthritis. So basically no organ is saved in the newborn when they develop invasive fungal infection. The clinical presentation obviously is fairly similar to other infections in the newborn, but there are some leading leading markers. For instance, thrombocytopenia. So presence of thrombocytopenia is both a risk factor and an indicator of some ongoing fungal infection, invasive fungal infection, specifically if the counts are less than 100,000 per microliter. Also, one can look at the left shift neutrophilia, and having immature to total neutrophil ratio of 0.2 or higher is an indicator. When I talk about thrombocytopenia, I also want to say here that it's important to not just look at the report of the platelets through Coulter, but it's also important to look at the slide and do an eye exam and do a manual counting of the platelets. Then, of course, these are all the telltale signs of worsening in a child with antibiotic. If there is an increased requirement of oxygen, is the new onset of apnea or bradycardia, increased ventilatory requirement, presence of lethargy, hypotonia, new GI symptoms, hypotension, having hyperglycemia. These are all clinical manifestations of invasive fungal infections. The evaluation, as I mentioned, requires a complete blood count, specifically a manual platelet count. And then it's so important to emphasize the role of trying to do a diagnostic test. And cultures should be drawn when we suspect invasive fungal infection in a newborn. We need to draw cultures, specifically blood, urine, and CSF. It is very important. Even if there is candiduria and there is clinical worsening, a dilated eye exam is very important. Ultrasound abdomen and ultrasound of the kidneys in all infants who have persistent candidemia. Many people still send the CVP tip culture. There is no role of doing a CVP tip culture in this when we suspect candidemia, because it can be colonized without concurrent infection. And then liver and renal function needs to be tested, because we will eventually need to treat these babies. Screening for dissemination, which means that you have a primary site, maybe there's a UTI, and you want to screen for dissemination. So the screening has to be done at the diagnosis when you have a culture which is positive for fungus. It's absolutely necessary. If the fungemia has persisted beyond 1 week, then it is very, very critical that we look for end organ involvement, an ultrasound to look at the liver and kidneys and the spleen, a chest x-ray, and all the tests that I previously mentioned. Indirect ophthalmoscopy with the dilated eye exam is very important. And if there is any necrotizing enterocolitis, history of peritoneal dialysis or a peritoneal tube, then we must send peritoneal cultures as well. And lumbar puncture should be done in all children in whom invasive candidiasis or any invasive fungal infection is suspected. Despite all the problems with cultures, and I'm going to talk a bit about that, taking cultures remains the gold standard for diagnosis of invasive fungal infections. And what is recommended is that once you have sent a culture, you can wait for 1 day or a couple of days. And if that culture has turned out to be negative, you have to send another culture. So the more cultures you send, the more the sensitivity increases. And as you know, with very small newborns, it is not possible to send large volumes. So cumulatively sending cultures up to 2 to 4 ml of blood improves the sensitivity and specificity to 75% and 85%. Urine cultures must be sent in all children in whom we are suspecting IFRs. Urine cultures positive for Candida species in newborns are significant, and they must be treated as invasive systemic Candida disease in neonates. Extremely low birth weight babies, specifically with candiduria, have near equal rates, and this is data that has come from Western countries, that even babies who had just candiduria, but they were extremely low birth weight, they have equal rates of neurodevelopmental impairment and death in those who have concurrently positive blood cultures and concurrently negative blood cultures. So clearly blood culture is, there's a high chance of not having a positive blood culture, but you need a high index of suspicion. CSF cultures are normal in almost half of the culture-proven Candida meningitis. However, there is data to show that majority of the infants who suffer from CNS candidiasis do not even have a positive blood culture. And that is why doing the CSF should be part of your workup of any child in whom you are suspecting an invasive fungal infection, irrespective of the blood cultures. Like I mentioned, the blood cultures may be negative in 50% of babies with candidiasis, and this has been seen in autopsy-proven candidiasis. So babies who had autopsy done and were found to have candidiasis, about 50% will have negative blood cultures because of all the reasons that I mentioned. And also this number of false negatives in the neonatal blood and CSF cultures we need to be aware of and have a high index of suspicion when we are trying to diagnose. The time to diagnosis is very important, and this has been a very difficult problem for treatment of neonatal candidiasis. Cultures usually take up to 2 days or 3 days or more to come out to be positive. And if you have previously started antifungal therapy, specifically when we are giving antifungal prophylaxis, then that culture positivity can be delayed for even up to 4 days. And waiting for culture results in the meantime can actually result in a significant delay in treatment, which is why there has been some research that is going on in the use of fungal biomarkers. Now, 2 commonly used fungal biomarkers also present in Pakistan commercially in the labs are the serum 1,3-beta-D-glucan, or commonly called as BDG, and the galactomannan assay, which is known as GALA. I'm not going to talk about GALA here because it is a specific assay for Aspergillus, and Aspergillus to date is still not a very common infection in the newborn, so we do not have a lot of data on the use and utility of GALA in newborn fungal infections. However, beta-D-glucan has been recommended as weak recommendation and moderate recommendation from the US infection societies and the European infection societies. So beta-D-glucan is present in the fungal cell wall, and although the data is limited, it has been shown that BDG is significantly higher in babies who have a fungal infection. So they may have levels of up to 976 picogram per ml compared to those who do not have a fungal infection, which is culture proven. Normal cutoff for BDG is 85 for adults. But the cutoff for newborns, because newborns, due to various reasons, have naturally higher levels of naturally higher levels of BDG, even in the absence of fungal infection. So the cutoff here, for which gives you 85% sensitivity and 75% specificity, is 125 picograms per ml. It is not a good test to determine starting empiric therapy. Remember that empiric therapy, which means that you start the treatment based on an index of suspicion, is empiric therapy should always be guided by your clinical instinct and the clinical signs and symptoms. However, it is a good marker for prognosis and also for confirming your diagnosis. With a specificity of 75%, there is a high likelihood that we may also miss invasive fungal infections with a normal BDG. So that is why index of suspicion and clinical instinct is much more important. Also remember that BDG levels can be falsely elevated, especially in case of some antibiotics, like specifically tazocin or piperacillin tazobactam, when there has been previous transfusion of RBCs or blood or FFPs. And a recent coagulase negative infection can result in a falsely elevated BDG. There are other markers in which work is ongoing, so they're not really biomarkers. So for instance, doing candidal PCR. So candidal PCR, if it can be developed as a quick test and relatively less expensive, is also a good testing modality. So like I said, empiric antibiotic therapy, early and appropriate, are the mainstay of treatment, especially in those who are at high risk. So, you know, those who are extremely low birth weight, who have central lines, who have recently been given broad spectrum antibiotics, specifically carbapenems and third generation cephalosporins, with abdominal pathology showing hypothermia, showing hyperglycemia and thrombocytopenia. So early initiation of empirical antifungal therapy and then the appropriateness of the therapy. Consider, and it's so important, and this is again an area of need in our setup, that we really need to know what the antibiograms of our institutions are like. So what is the sensitivity pattern of the candidal infections? So the institution's antibiogram should guide your first line therapy. And also it's very important, if the baby is already on fluconazole prophylaxis, then you cannot start treatment with fluconazole. So therefore, I mean, I should have added another line. Amphotericin remains the first line antibiotic for treatment of invasive fungal infections. You always start with amphotericin. And I will explain later some of the reasons for that. So this is work that was recently published and done in the neonatal ICU at Jehan University, where they looked at the trends of isolation of Candida species from 2014 to 2019. And this pointer is not working, right? So as you can see in this, that there has been a significant decrease. So what you see, the top gray line that you see is Candida tropicalis. So Candida, and the diamond with the dark line is the Candida albicans. So if you look at the second line, which starts at 28%, you see that the Candida albicans prevalence has decreased significantly from 28% to 11%. And this has really been the result of a large broad-scale implementation of antifungal prophylaxis with fluconazole. However, what has happened as a result of that is that other Candida species, which may be inherently resistant to fluconazole, their occurrence has increased. So AKU is now seeing more of Candida tropicalis and Candida parapsilosis, which may not necessarily be sensitive to IV fluconazole. This is the same study which is showing the resistance to two commonly used antifungal therapies, and this is for AKU, resistance to fluconazole and voriconazole by the Candida species. And we are looking at two types of diseases, early onset disease, Candidemia, and late onset Candidemia. So as you can see, for neonates with early onset disease, what you are seeing in the column, so for Candida albicans, it is showing you the non-sensitivity with fluconazole, the non-sensitivity with voriconazole. So in this study, there were 22 isolates of Candida. Of them, Candida albicans में जो है, there was no of the 30 isolates of Candida albicans, there was no non-sensitivity. So all albicans is nearly 100% sensitive to fluconazole. So no non-sensitivity. But when you look at tropicalis, there is 1.4% that may be non-sensitive. It is high for glabrata, for pelliculosa, utilus, and Gulliramundi, as well as other Candida species. And this is so important to know because a lot of times the microbiology lab would report that there are budding yeasts. And we always tend to, as a knee-jerk, start fluconazole in therapeutic doses. But it is important to know that with the changing epidemiology, less and less albicans and more of other non-albicans Candida we are seeing. So fluconazole should not be our first line of therapy. Even if we are thinking of Candida albicans, if the child is septic, if he's hypotensive, if he's manifesting infection of more than one organ, it is recommended to again not give fluconazole but give amphotericin, because fluconazole is largely it's static, bacteriostatic in nature, and then it has variable absorption. So amphotericin B deoxycholate, there are two types of amphotericin, amphotericin B, which is the commonly available amphotericin, and the liposomal amphotericin B. So liposomal amphotericin B has consistently been shown to have more treatment failure when given to newborns with invasive fungal infections. So what is recommended is amphotericin B deoxycholate, and fluconazole should be avoided specifically in those who have received fluconazole prophylaxis and those who have glabrata and Kruse infection or where you are suspecting it, and non-candidal infections. Other echinocandins are also available like caspofungin and micafungin. Micafungin has been used routinely in the West and several low middle income countries. I do not have any personal experience of its use. If there is anybody out there who does, I would really recommend you to publish it. And these echinocandins are actually good as add-on therapy with amphotericin. They have favorable safety profile, and they're not good for urinary infections. Please remember that. So echinocandins should not be given for Candida UTI. And caspofungin, which is commonly used in adults or older children, is not recommended, especially in children less than 2 years of age. So what are our therapy goals? When we treat them, what do we want? We want to have at least 2 negative blood cultures. And it's important to document this because Candida can present in the blood in showers. So you may have a negative blood culture, then you may have a positive blood culture, then you may have a negative culture. It is important to document 2 consecutive negative blood cultures. It is also important to try to document a negative urine culture. And if possible, we don't usually do it, if possible, a negative CSF culture, especially if the initial culture was positive. Source control is the mainstay. Source control is the mainstay, removal of all central lines, tubes, shunts, implants, and antifungal therapy needs to be given for at least 2 weeks after evidence of clearance of infection. A little bit about Candida auris. It is an emerging pathogen, and amphotericin B is currently recommended for infants aged under 2 months of age, and caspofungin, which is a common drug for Candida auris, is not recommended. Like I mentioned, prevention is the mainstay. I have a few slides on this, but I will not talk much because I know that there is a session on antibiotic stewardship, and I think I've taken a lot of time. My apologies. So central line care is obviously there. I mean, these slides can be available to the participants if you want to share. It's important to maintain insertion bundles and maintenance bundles of central lines. If your unit is inserting central lines, you need to do this checklist. This is a standard checklist, universally internationally used. Antibiotic stewardship, this is a guide to what the antibiotic stewardship team can look like. Antifungal prophylaxis as part of the CLABSI prevention package. So again, this is intervention work which was done at Jehan University, where we gave organism-specific prevention for fungal infections. So all babies who were less than 1 kg were given prophylactic fluconazole, were stopped early or not given H2 receptor blockers, and were given stewardship. And with that, what we saw was a significant decrease in the overall rate of infections when we started from the first phase to the third phase of the study. So nearly zero central line infections. Just a couple of slides on new therapies under investigation. So oral bovine lactoferrin. Lactoferrin is normally present in the breast milk, and it has antimicrobial properties. Work is ongoing around its role in prevention of fungal infections, the use of probiotics, as well as the use of commonly available probiotics in prevention of infection, including invasive fungal infections. This is a summary of the timeline of prevention and treatment of candidal infections, and a slide showing you the future research directions. I spoke about it during my talk, and thank you for your patience.